Here's the single question that solves almost every USMLE connective tissue, cartilage, or bone vignette. Is this a collagen synthesis defect, a mineralization defect, or a cell activity problem? Get that framework down, and half these questions answer themselves. In this video, we're covering connective tissue, cartilage and bone, blood, muscle and nerve and glands, and I'll drop timestamps in the description below if you want to jump straight to one. Let's start with the big picture. The 4 basic tissue types every organ in the body is built from. Every organ in your body is really just these 4 tissues, combined in different proportions. Epithelium comes from all 3 germ layers, and it's built for covering, lining, secreting, and absorbing. Connective tissue comes from mesoderm, and it's the support structure. It also handles immune defense and nutrient storage. Muscle, also mostly mesoderm, generates force and movement. And nervous tissue, from neuroectoderm, generates and conducts signals. Here's the distinction that matters most on your exam. Epithelium has almost no extracellular matrix and no blood supply of its own. Connective tissue is the opposite. It's defined by abundant ECM, and it's generally vascular. That single distinction underlies most histology questions comparing the two. Connective tissue is defined by one thing epithelium doesn't have: an abundant extracellular matrix made of fibers sitting in ground substance. Type 1 collagen is your classic high-tensile strength fiber. That's tendons, ligaments, bone, and dermis. Type 2 collagen is thinner, and it's what gives hyaline and elastic cartilage their structure. Type 3, also called reticular fibers, are thin and branching, and because they're silver-stainable or argyrophilic, they show up in lymphoid organs, the liver, spleen, and bone marrow stroma. Type 4 doesn't form bundles at all. It's sheet-forming, and it makes up the basement membrane. And elastic fibers combine an elastin core with a fibrillin microfibril sheath. You'll find those in large arteries, the vocal cords, elastic cartilage, and lung tissue. Here's the exam strategy. Whenever you see a collagen fiber question, the location in the vignette is usually the fastest way back to the type. Ground substance is the gel that fibers sit in. Glycosaminoglycans, or GAGs, are long, negatively charged chains that bind water, which is why the matrix resists compression instead of just squishing flat. Proteoglycans are those same GAGs attached to a core protein. Agrican is the classic example, aggregating around hyaluronic acid in cartilage. And glycoproteins like fibronectin and laminin are the glue. Fibronectin links cells to the ECM, laminin anchors things in the basement membrane. Now here's a pearl worth knowing cold. Vitamin C is a cofactor for the enzymes that hydroxylate proline and lysine during collagen synthesis. Without it, you get scurvy, poor wound healing, bleeding gums, corkscrew hairs. Because this is fundamentally a collagen problem, it connects to 2 other classic vignettes: osteogenesis imperfecta, a type 1 collagen defect causing brittle bones and blue sclerae, and Ehlers-Danlos syndrome, where the collagen cross-linking itself is defective, giving you hyperextensible skin and joint hypermobility. Connective tissue has resident cells that are always there and transient cells that show up when needed. The fibroblast is the main resident cell. It's the one actually synthesizing the collagen, elastin, and GAGs you just learned about. Macrophages handle phagocytosis and antigen presentation, and they come from circulating monocytes. Mast cells are packed with histamine and heparin granules, and they degranulate through an Ig-mediated mechanism. That's your type 1 hypersensitivity reaction. Plasma cells are terminally differentiated B cells that pump out antibody. On histology, look for that clock-face nucleus with the paranuclear halo. Adipocytes store lipid as white fat or generate heat as brown fat through UCP1. And leukocytes are transient. They only show up during inflammation. Here's a distinction worth locking in. Mast cells and basophils both degranulate in type 1 hypersensitivity, but mast cells live in tissue while basophils circulate in blood. And chromalin sodium works by stabilizing the mast cell membrane. That's why it's used for asthma prophylaxis. There are 8 subtypes of connective tissue proper, and each one is defined by how its fibers are arranged. Loose or areolar Tissue has sparse fibers and lots of cells. You'll find it right beneath epithelium and around vessels and nerves. Dense regular tissue is the opposite, tightly packed, parallel collagen bundles with very few fibroblasts, built for pulling in one direction. That's tendons and ligaments. Dense irregular tissue has that same collagen, but woven randomly, so it resists stress from multiple directions. Think the reticular layer of the dermis, or an organ capsule. Reticular tissue is that fine type 3 collagen meshwork forming a supportive scaffold. Lymph nodes, spleen, marrow, and liver stroma all depend on it. White adipose tissue has one big lipid droplet per cell, giving it that signet ring look, and it's built for storage and insulation. Brown adipose tissue is different. Multiple small droplets, packed with mitochondria expressing UCP1, and it's how newborns generate heat without shivering. And mesenchyme is where all of this comes from. It's the embryonic connective tissue, made of undifferentiated stellate cells sitting in a gelatinous matrix, and it gives rise to every adult connective tissue type you just learned. One more variant worth knowing. Mucous connective tissue, or Wharton jelly, has that same gelatinous ground substance with very few fibers. You'll find it in the umbilical cord. Cartilage is avascular and annural, so it depends on nutrients diffusing in from the surrounding perichondrium. Immature chondroblasts sit at the periphery, secreting matrix, and as they mature into chondrocyte, they get trapped in spaces called lacunae, often in clusters called isogenous groups. Hyaline cartilage has type 2 collagen, and on light microscopy the matrix just looks glassy and homogeneous. You'll find it at articular surfaces, the trachea, bronchi, nose, costal cartilage, and the fetal skeleton. Elastic cartilage has that same type 2 collagen, but with a dense elastic fiber network added in. That's your external ear, epiglottis, and larynx. Fibrocartilage is different. It has both type 1 and type 2 collagen. It has no perichondrium at all, and its chondrocyte line up in rows. You'll find it in intervertebral discs, the pubic symphysis, menisci, and tendon bone junctions. And remember, articular cartilage and fibrocartilage are the two places without a perichondrium. So on the exam, if the matrix looks glassy with no extra fibers, it's hyaline. If you see coiled elastic fibers, it's elastic. And if the chondrocyte are sitting in rows between thick collagen bundles, that's fibrocartilage. Cartilage grows two ways. Appositional growth adds new cells from the perichondrium at the surface, and interstitial growth happens when chondrocyte already inside a lacuna divide from within. Now, when a gene called FGFR3 gains function instead of losing it, it impairs that interstitial growth specifically at the epiphyseal plate, the site of endochondral bone growth. That impaired growth plate is what gives you achondroplasia. It's the most common cause of dwarfism. It's autosomal dominant, and on your exam, short limbs plus a normal trunk should immediately point you toward an FGFR3 problem at the growth plate. Bone is mineralized connective tissue. Its matrix, called osteoid, is type 1 collagen plus ground substance, mineralized with hydroxyapatite crystals. That whole lineage starts with the osteoprogenitor cell, a mesenchymal stem cell sitting in reserve in the periosteum and endosteum. It differentiates into an osteoblast, which actually synthesizes the osteoid and secretes alkaline phosphatase. Once an osteoblast gets surrounded by its own matrix, it becomes an osteocyte, trapped in a lacuna, but still alive, maintaining the matrix and communicating with neighboring osteocytes through canaliculi. The osteoclast is the odd one out. It doesn't come from mesenchyme at all. It's from the monocyte macrophage lineage, and multiple cells fuse together to form one multinucleated cell built for resorption. It resorbs bone through a ruffled border, using H+ ADPase and acid hydrolases to dissolve the mineral and matrix. And the regulation is worth memorizing. RNKL stimulates osteoclast activity, while osteoprotegerin and calcitonin both inhibit it. That balance is what most bone pathology questions are really testing. Macroscopically, bone comes in two forms. Compact bone is the dense outer layer. It's organized into osteons or haversion systems, concentric rings of lamellae wrapped around a central haversion canal that carries vessels and nerves. Those osteons connect to each other through perpendicular perforating or Volkmann canals. Spongy or trabecular bone is the interior meshwork. No osteons here at all, just interconnected trabeculae. The spaces between those trabeculae are where bone marrow lives. And because of that open structure, spongy bone has far more surface area than compact bone, which is exactly why it's the more metabolically active of the two. It's where most of the remodeling actually happens. There are two ways bone actually forms. Intramembranous ossification is the direct route. Mesenchyme differentiates straight into osteoblasts with no cartilage step at all. That's how the flat bones of the skull and the clavicle form. Endochondral ossification is different. You start with a hyaline cartilage model, and that model is progressively replaced by bone. Growth happens at the epiphyseal, or growth, plate. This is how your long bones form, and really most of the axial and appendicular skeleton. And this is exactly why achondroplasia causes short limbs, but a normal-sized skull and clavicles. The FGFR3 mutation only disrupts endochondral growth at the plate. The bones that form intramembranously are completely spared. Blood is technically a connective tissue. Its formed elements, the cells, are suspended in a liquid extracellular matrix called plasma. The erythrocyte, or red blood cell, is anucleate and biconcave, lives about 120 days, and carries oxygen bound to hemoglobin. The neutrophil has that classic multilobed nucleus, and it's your first responder in acute bacterial infection. Eosinophils have a bilobed nucleus and bright red-orange granules. Think parasitic infection and allergy. Basophils are rare, with dense dark granules full of histamine and heparin, same type 1 hypersensitivity mechanism as mast cells. Lymphocytes have a large nucleus and barely any cytoplasm. That's your B cells, T cells, and NK cells running adaptive immunity. The monocyte is the largest circulating leukocyte with a kidney-shaped nucleus, and it's the cell that differentiates into tissue macrophages once it leaves the bloodstream. And finally, the platelet. Not even a full cell, just an anucleate fragment pinched off from a megakaryocyte, doing the job of hemostasis. 7 formed elements, each with a distinct job. And on your exam, recognizing the nucleus shape is usually the fastest way to identify the cell. Quick check before we move on. Do you remember which formed element is anucleate, biconcave, and lives about 120 days? You just covered it a minute ago. Drop your answer in the comments. So, where do all 7 of those formed elements actually come from? It all starts with a single hematopoietic stem cell, which branches into common myeloid or lymphoid progenitors, then into lineage-committed precursors, and finally into the mature formed elements you already know. The site of hematopoiesis actually changes across life. It starts in the yolk sac around weeks 3 to 8, shifts to the liver and spleen for most of fetal life, and then bone marrow takes over from around the 5th month onward, becoming the exclusive site after birth. Red marrow gradually gets replaced by fatty yellow marrow in the long bones after childhood, though the axial skeleton holds onto its red marrow. One board pearl worth remembering: in marrow failure states, myelofibrosis, severe hemolytic anemias, thalassemia major, the liver and spleen can reactivate and take hematopoiesis back over. That's called extramedullary hematopoiesis. There are 3 types of muscle, and the exam loves comparing them directly. Skeletal muscle is striated, multinucleated with the nuclei pushed to the periphery. It's voluntary, and it's controlled through the neuromuscular junction. Cardiac muscle is also striated, but each cell usually has just one central nucleus. It's involuntary, driven by the autonomic nervous system plus its own pacemaker, and its cells connect through intercalated discs, gap junctions for electrical coupling, desmosomes for mechanical strength. Smooth muscle is the odd one out structurally, non-striated, spindle-shaped cells, single central nucleus, and involuntary. Here's a distinction worth knowing cold. In skeletal and cardiac muscle, calcium triggers contraction by binding troponin C on the thin filament. In smooth muscle, there's no troponin. Calcium binds calmodulin instead, which activates myosin light chain kinase, regulating the thick filament directly. And regeneration capacity tracks with how specialized each tissue is. Skeletal muscle has limited regeneration through satellite cells, cardiac muscle has almost none, and smooth muscle actually retains good mitotic capacity. If a vignette asks which muscle can still divide and repair itself after injury, smooth muscle is usually your answer. Zoom into skeletal or cardiac muscle far enough, and you hit the sarcomere, the actual contractile unit. The A band is the dark zone made of thick myosin filaments, and its length stays constant during contraction. The I band is thin actin filaments only, and it shortens. The H zone is the central part of the A band with just myosin, and it shortens too. The Z line anchors the thin filaments through alpha-actinin, and it marks the boundary of each sarcomere. The M line sits centrally, anchoring the thick filaments. Here's how contraction actually happens. Calcium binds troponin C, which shifts tropomyosin out of the way, exposing the myosin-binding sites on actin. Myosin's ADPase then drives cross-bridge cycling, pulling the actin filaments toward the center, and that's what shortens the sarcomere, while the A band itself stays the same length. Two classic correlates come out of this system. Duchenne muscular dystrophy is an X-linked dystrophin mutation that makes the membrane fragile, causing that pseudohypertrophy of the calves you'll see in vignettes. And myasthenia gravis is autoantibodies against postsynaptic acetylcholine receptors at the neuromuscular junction, causing fatigable weakness. Let's break down the neuron itself, starting with the cell body or soma. That's where the nucleus lives, along with Nissl bodies, which are just rough doing protein synthesis. Dendrites receive input, and they use spines to increase their surface area for more connections. The axon conducts the action potential away from the soma. It may be myelinated, and it ends in synaptic terminals. And the axon hillock deserves special attention. It's where the action potential actually starts, because it has the highest density of voltage-gated sodium channels of any part of the neuron. By shape, unipolar neurons have a single process, technically pseudo-unipolar in vertebrates, and you'll find them in sensory ganglia. Bipolar neurons have one axon and one dendrite, and they're specialized for sensory relay. Think the retina, olfactory epithelium, and vestibulocochlear ganglia. And multipolar neurons with many dendrites and one axon are the workhorse. Most CNS neurons and motor neurons fall into this category. Neurons don't work alone. 6 types of glial cells support them, and the exam expects you to know each one's job and location. Astrocytes live in the cysts. Their end feet form the blood-brain barrier. They buffer potassium, take up glutamate, and form glial scars. GFAP is their marker. Oligodendrocytes, also CNS, myelinate multiple axons at once, which is exactly why they're the target in multiple sclerosis. Schwann cells are the PNS equivalent, but each one only myelinates a single axon segment, and they also guide regeneration after nerve injury. Microglia are the CNS's resident macrophage, and unlike the other glial cells, they're actually mesodermal in origin, doing phagocytosis and immune surveillance. Ependymal cells are ciliated. They line the ventricles and central canal, and they produce and circulate cerebrospinal fluid. And satellite cells sit in PNS ganglia, supporting neuronal cell bodies. Think of them as the PNS's version of astrocytes. The ratio worth memorizing. One oligodendrocyte myelinates many CNS axons, but one Schwann cell only ever myelinates one PNS axon segment. Myelin's job is insulation. It restricts ion flow to specific gaps called the nodes of Ranvier, and that's exactly what enables fast, saltatory conduction, where the signal essentially jumps from node to node. And remember, one oligodendrocyte handles multiple CNS axons, while one Schwann cell only handles a single PNS segment. When that myelin breaks down, you get demyelinating disease. Multiple sclerosis is autoimmune demyelination in the CNS, driven by oligodendrocyte damage. Guillain-Barré syndrome is the PNS version, autoimmune demyelination targeting Schwann cells, and it's often triggered after an infection. One more nervous tissue correlate worth knowing, even though it's not a demyelinating disease: Alzheimer's disease, characterized by neurofibrillary tangles made of tau protein, along with amyloid plaques. Glands are epithelial-derived secretory structures, and they're classified two ways: by where the product goes and by how structurally complex they are. Exocrine glands secrete through a duct onto an epithelial surface. Sweat glands, salivary glands, and the acinar portion of the pancreas all work this way. Endocrine glands have no duct at all. They secrete hormones directly into blood or lymph. The thyroid, adrenal, and pituitary are your classic examples. Now let's look at how exocrine glands specifically get organized structurally. Exocrine glands get classified along two separate axes: how the duct branches and what shape the secretory unit itself takes. By duct branching, simple glands have one unbranched duct, like the intestinal glands. Compound glands have a branched duct system. That's your salivary glands and the pancreas. By secretory unit shape, tubular glands, like the intestinal crypts, are simple tubes. Acinar or alveolar glands form small grape-like clusters. The exocrine pancreas and the mammary gland fit here. And tubuloacinar glands combine both shapes. That's the salivary glands. So notice, the salivary glands actually show up in both classifications at once. They're compound by duct branching and tubuloacinar by secretory shape. That's the kind of detail vignettes like to test. The last way to classify a gland is by its actual secretory mechanism, how the product leaves the cell. Merocrine secretion is exocytosis. The cell stays completely intact. Salivary glands, the pancreas, and eccrine sweat glands all work this way. Apocrine secretion is different. The apical cytoplasm itself pinches off along with the product. That's how the mammary gland secretes lipid, and it's also how apocrine sweat glands in the axilla work. And holocrine secretion is the most extreme. The entire cell disintegrates to release its contents. Sebaceous glands are the classic example. If you're not sure which mechanism a gland uses, merocrine is the safe default. It's how most glands in the body actually secrete. But if a vignette describes a gland where the whole cell breaks apart to deliver its product, that's holocrine. The cell doesn't just make the secretion, it becomes the secretion. Let's round up every clinical correlate from these notes, starting with the collagen and cartilage disorders. Scurvy, vitamin C deficiency impairs collagen hydroxylation, which is why you get poor wound healing, bleeding gums, and corkscrew hairs. Osteogenesis imperfecta, a type 1 collagen defect, giving you brittle bones, blue sclerae, and hearing loss. And achondroplasia, an FGFR3 gain-of-function mutation that impairs endochondral ossification, resulting in short-limb dwarfism. Notice the pattern. 2 of these 3 are collagen problems, and 1 is a growth plate cell signaling problem, exactly the framework I opened this video with. Rounding out the correlates. Osteoporosis is excess osteoclast activity, giving you porous, weak bone, while osteopetrosis is the opposite, defective osteoclast function, giving you dense but brittle marble bone. Duchenne muscular dystrophy is that X-linked dystrophin defect, causing progressive proximal weakness and pseudohypertrophy of the calves. And multiple sclerosis versus Guillain-Barré comes down to which compartment is being demyelinated: CNS oligodendrocytes for MS, PNS Schwann cells for Guillain-Barré. And that brings us back to where we started. When a vignette describes a connective tissue, cartilage, or bone disorder, ask yourself, is this a collagen synthesis defect, a matrix mineralization defect, or a cell activity defect? osteoblast, osteoclast, or chondrocyte. That one framework resolves most histology-based pathology questions on your exam. That's every high-yield framework from this histology set: epithelium versus connective tissue, and the collagen versus mineralization versus cell activity question that unlocks most of these vignettes. If this helped, subscribe. I'm building out the rest of Step 1 subject by subject, and I'd rather you have it than have to piece it together yourself.